Welcome to another episode of Endo Untangled. My name is Alecia Macrow. Due to some slight technical difficulties, we unfortunately don't have Cherie with us this morning. So I'm going to do my best job of being Cherie and Alecia this morning. We have two special guests with us today. We have Dr James Hillhouse, who is an interventional radiologist based in Orange, New South Wales. And we have Sarah Thorncraft, a nurse practitioner candidate, who is the lead of the endometriosis and pelvic pain clinic in Orange as well. James and Sarah, welcome to the podcast.
Thanks for having us.
So exciting to have you here. What we're talking about today is pelvic vascular congestion, pelvic venous disease. I'm so interested to pick both of your brains on this. Sarah, tell us a bit about your work. So you're working in the endo clinic in Orange, but I'm curious about what that looks like for you, but also how you ended up working with James.
I was myself a pelvic pain patient with extremely debilitating symptoms for about 12 years before I got wonderful multidisciplinary coordinated care that changed my life. And I was a young RN at the time, and I just went, this should be everywhere. And so in that spirit, I went back to uni and I did a Master of Women's Health Medicine, and I've just been upskilling myself in that space ever since, and having very little opportunity to use it. So when the grant came out for these clinics, I just jumped at the chance to do what I've always dreamed of doing with the training. And having had an experience as a patient, it's really lovely for me. And now to be going into nurse practitioner studies as well, it's really lovely for me to get up and go to work and be the kind of clinician that somebody once was for me. I met James when I got a grant to open one of the clinics, and I heard along the grapevine that I was lucky enough to have not only a fabulous deep endo ultrasonographer, but also somebody in town who could report a deep endo MRI. So I was very, very excited about that. Then a few months later after that, I discovered that James was also an interventionalist and that he could fix fibroids and adenomyosis as well. And then eventually we met in person when he came to do a lunchtime talk at our clinic. And that talk was about not only adenomyosis, but pelvic venous disorders. And at that point, I realised there was a really great opportunity for a collaborative care model where we could give each other real-time feedback between symptoms that we were hearing and what we were finding on radiology. And that's kind of how things got started.
My journey to this is I'm an interventional radiologist and diagnostic radiologist that's trained in Sydney in both the diagnostic and then interventional components. Moved to Vancouver to do further training in diagnostic abdominal imaging, which included gynecology-specific imaging as well. And then came and settled back into Orange, which is where I spent a few years in medical school in my junior years, and kind of desperately desired to come back for the lifestyle. And kind of just fell into it. I think happenstance occurred when the pelvic kind of endo clinics were being funded, and Orange was lucky enough to have one. Then I think now I do a whole host of general IR procedures, but female urogenital work would form probably 90% of my work.
All right, let's talk about pelvic venous disease. What's the story with it? Is it a serious contributor to pelvic pain or not?
Look, yes, it is a serious contributor, and certainly under-recognised, and that's what the data and the literature supports, which is mainly sitting in the retrospective space at the moment. But good data, historic data, has suggested that of the women presenting to a clinic with the specific complaint of a chronic pelvic pain condition, being pain experienced for 6 months or more, about 30% of those will have a venous component to their pain. Now, that doesn't mean that it's 30% of patients have dominant venous pain. It just means 30% have a venous component. Now, as you will know, Alecia, and as all your listeners should be well aware, again, supported by the literature, the vast majority of pelvic pain is multifactorial. And I think when any clinician and even patients approach the pelvic pain that sits in front of them or that they experience as looking for a single source or single lesion, they're not going to have a satisfying experience the majority of the time. So what is pelvic venous disorder? Well, it's disordered and dysfunctional veins. So we have to first think about what do veins actually do. So veins, when they're working properly, take blood that's come from the arterial system, perfuse the vital organs or the tissues of our body, and the veins' job is simply to transport blood back to the right side of the heart through the lungs for oxygenation and back into the arterial system. So a normally functioning vein allows blood to flow back to the heart. That's what it does. So a venous disorder is simply a vein that does not do that. And that could be through a whole host of conditions. That could be because simply it's thrombosed. We all know superficial thrombophlebitis. Patients had a cannula, it's thrombosed. That vein does not work now for that period of time.
So
Varicose.
Yes,
It's got a clot. It's blocked,
Yep.
and that's just simply one aspect, a thrombotic cause of a venous disorder. It's not allowing that vein to work anymore. That can happen in the lower limb, a DVT, and we're well aware that patients present symptomatically when they have a DVT. They have a painful leg, it's swollen, it will ache, it can be itchy. So there can be a thrombotic cause. There can be an obstructive cause, a mechanical obstruction rather than thrombotic. There's also refluxing or valvular issues where the valves in the veins do not work anymore. So in veins, they're not like the arteries where there's a big pump pushing blood through the arteries. Veins rely on us to move. They rely on our muscles to squeeze. They rely on bits of movement to swirl blood back through these veins. The veins have valves like a duckbill, and that valve opens up, and then when we stand up or when gravity pushes back down, it snaps closed, and the blood is allowed to walk up that vein like the rungs of a ladder. In a refluxing condition rather than, say, an obstruction condition, the veins might get to a point where they are distending up until such a time where that valve is no longer touching and there is no ability for that blood to walk up those rungs of a ladder. And similarly so, when gravity takes over and pushes down, the blood flows down the wrong way, and that outflow tract of that venous reservoir is now dysfunctional, and that venous reservoir becomes hypertensive with venous hypertension, and that's what causes the symptoms.
a varice is a fat, high-pressure vessel vein?
Distended,
right?
yeah, a distended vein, and it could be due to high pressure and obstructive causes, or it could be due to reflux causes.
Yeah, I was having a think, James and Sarah, yesterday about what might an analogy be. So if the pelvis is a city, it's like lots of people in their cars can get into the city, but the roads out of the city aren't functioning properly. And so people can get into the city but can't get out of the city in their cars. And then sometimes some of the roads that should be the out roads, there's actually more cars coming in backwards in that way. And then there's more and more cars in the city leading to congestion.
Perfect
Thoughts?
analogy. Use it all the time.
Yeah.
Do you?
Yeah, I've used it all the time to
Yeah.
describe, the redirecting of traffic through the treatment process of whether we need to actually open up the highway or whether we actually say, look, this highway is broken, the road is not good. We actually just need to close it down and allow the traffic to find the other smaller side roads to get out.
Yes. Okay, so we've got an overloaded, congested city, Sarah, in the pelvis. What do you think, if you're speaking to someone with pelvic pain, what symptoms are you starting to think, I wonder if pelvic venous disease is part of their picture?
I would start this by saying when I first opened this clinic, I did not have any concept of pelvic venous disorders as a thing. I just did not know anything about it. I didn't know it caused pain. And for me, it was a couple of patients who had every single other thing treated, and they just weren't getting better. And they were such beautiful historians that when I heard about what pelvic venous disorders tend to present like, I came out of that talk that James did and went, oh my gosh, I need to make some calls. And when we first started, there was a few things that kind of would ring alarm bells for me and think, okay, I maybe need to think of venous, and I'll go through some of those in a moment. But I think the other thing to know is that I think because the research to this point has been quite siloed and there hasn't been that communication between the vascular literature and the gynecology literature, we're not putting two and two together like we could be. And so that's what I'm hoping that at some point I can change, because I do have such a privilege to have that instant feedback of going, these are the symptoms and exactly what we found. So some of the really common ones are the things that you'll see in other venous disorders. So you'll see that lower limb claudication, patients that have pain with prolonged standing that need, seems to help when they wear compression socks, or if they heavy lift. It's like the same kind of dull, dragging, aching pain that they'll have. And it can be diffuse. So they can just say, look, I've just got pain everywhere. But oftentimes they will actually locate that right on top of the gonadal veins. So they will actually, depending on where the venous issue is, they will often point you straight to it. So the simplest thing to ask them when they say they have pelvic pain is to say, okay, where? And then we go from there. Because almost always in my experience, if you ask them where and you go looking and you find symptoms that match with a varice in that exact same spot, you're onto a right track. So, for example, and I see this all the time in practice, and I hope this helps to speak to those who sort of don't think it's a thing. I have often seen patients who've got an endometriotic lesion on one side of their pelvis, and it's superficial and it's sitting there, and they've got known endometriosis. But they complain that their pain is right next to their cervix and they ache after intercourse. And if I find a huge, big, fat vessel right there, I'm not blaming their endometriosis for that pain, because it makes absolutely no sense to do so. So that's kind of the first thing I would say, is that the site of pain is really important. And I think as clinicians, we need to go back to that old Socrates mnemonic and blow the dust off it and get really good at what that looks like. So they're we have to listen to where their pain is and correlate that with clinical findings on their imaging and go, okay, they've got pain here and they've got endo there. Does that make sense? Or they've got pain here and they've got heaps of adeno. But if their pain's inguinal fossa, it's probably not the adeno driving their pain. It's over here. So it's just about it's not a competition. It's not an either or situation. It's about trying to match symptoms, hearing what our patients are telling us and what's bothering them, and going, right, what fits pathophysiologically? So these patients will also talk about so their onset is generally really like they're in daily pain by this point. And this is why they turn up to chronic pain clinics, because they don't just have pain with periods anymore. They are in pain all the time, and they won't describe generally. If they describe stabby pain or pain that drops them to their knees, that generally is a musculoskeletal thing, or it might be associated with lesions. But these pains, they'll describe it as, this is dull, it aches, it's terrible at the end of the day. I'm all right in the morning when I get up. They will say that it feels heavy, or sometimes they'll say, I feel like everything's going to fall out, and you think you're going to find a prolapse and there isn't one. It just feels heavy and dull and achy in their pelvis. It can refer sort of into their back, down their legs, much like endo pain can. But the associated symptoms are also many. So these patients will complain primarily, the biggest one for me, if I can take this home with anybody, is when you first get started out, if they have deep dyspareunia that aches the next day, you have to suspect that that could be venous. And also we have to ask some nitty-gritty questions about that. So when we're talking about dyspareunia,
and just to interrupt, just for someone who might not be medical, so that's pain during intercourse.
Yes,
or associated with intercourse. Yep.
Yes. So
Yes, critically associated with intercourse. So it's a and again, sorry to interrupt, but this is such a poorly used term because people just say, "Do you have pain with sex?" And they don't then go ahead and say, "Well, is it during sex? Is it after sex? Is it the next day? Is it in fact pain with arousal?" This kind of throw out term of pain associated with sex really needs the time and careful history teased out of it, which obviously Sarah does so wonderfully.
yeah, so in terms of pain with sex, oftentimes, like I say, it's that really, really sensitive history taking. These patients will tell you that it can be a little bit uncomfortable at the time, but they would tell you that they ache like nothing else the next day. They will often just say, oh, the prolonged ache. And often that doesn't even require penetration. So orgasm alone, because you're getting infiltration of blood into those tissues, the blood can get in, the traffic gets in, it can't get out. So those questions are really important because generally speaking, that's not an endo-related pain unless they've got an adhesion that's really playing up on them. And I find that out very quickly because I do a digital exam and I just move their cervix and I say, is that it? And they'll often go, nah. And if their cervix moves and that's not their pain, and if I've got a good ultrasound on them that says they don't have endo sticking all of that together, then that tells me that there's something going on there. Venous patients also often complain of pain with arousal. They'll often also tell you they've often got comorbid hemorrhoids, or they'll complain of bowel complaints. So they'll say, oh, gee, it hurts to do a poo. But when I question them and say, well, are you constipated? And I pull out my Bristol stool chart and say, point, which poo's yours? They point to a perfect poo and they're doing all the right things with their medications and their fibre. It's just that it hurts to bear down because it pushes all the blood into their pelvis and they hate it and they'll get pain for some time afterwards because it causes the blood to get in and it can't get out. So that's probably another thing that is generally pretty helpful to know. Venous pain tends to be exacerbated with ovulation. They'll often have heavy periods, but sometimes for some reason that it's often that mid-cycle flare that really gets them. And if they've been on their feet all day or they've been heavy lifting, so the patients that I'm always suspicious of, what do you do for a living? I'm a hairdresser. I had one lady who was a panel beater, so she spent all day lifting heavy things. Nurses, theatre staff, they're chronically standing and they'll tell you that they feel worse those days, and it just makes perfect sense.
Sarah, I'm just thinking, this is so many people that we see in clinic, isn't it? Like,
it really
it's
is.
Kind of overwhelming.
It is.
and I think the really important part is it's got to be the and not the or, because it doesn't mean that you can't have endo. It doesn't mean that you can't have bowel dysfunction or pelvic floor dysfunction. You've possibly got all of those things.
I've hardly come across a patient with venous disease that didn't have at least one other comorbidity, and it's been blamed for all of their symptoms, but no one's listening to the symptom of bother, and I think that's where we've got to go. What I really want people to see is that there are flagship signs of pelvic venous disorder that are actually quite distinguishable from endo-related pain in someone who has put lots of effort into learning what those flagship signs are. I think for most, if we can take away from this that as health professionals, I didn't know this existed either. So there's no judgment from me, but just because we don't understand it doesn't mean it doesn't exist. And I think that this is a point at which we can look at the vast array of evidence that we have. It's all there in the vascular journals. And I would say to anyone who thinks that this is not an existing condition, that it's an incidental finding, I would just impress upon every clinician to go to the vascular literature because it is all there. And I didn't know about it either because it doesn't often cross over the silo between vascular literature and gynecology literature, but it's all there.
Yes, it's amazing that we've got these endo clinics. There's initially 22 and now 33, and we're all kind of seem to be going on this same journey where we thought we were looking after endometriosis, and we are, but we're actually looking after all this other stuff at the same time. Right, so Sarah, so you've got someone you're suspecting that they've got some sort of venous component to what's going on. What's happening next? What do you do?
Yes. So if I suspect that they have a venous component, so first and foremost, I want a really good ultrasound on them, and I want a good scan that tells, or MRI if they can't have an ultrasound at some point. That's because I want to exclude all of the nasty things that could be happening aside from that as well. If that's already been done, then I just want to have a look at their vessels and how that's functioning. So I'm very, very thankful that I have a sonographer that works with me and will report if I've got big vessels at the same time as she's doing a deep endo scan. But that isn't always the case and hasn't always been the case. So what I would do in a patient who that's suspected of is I would first send them for a Doppler to try and check their abdomen and their pelvic venous channels to see if they have, firstly, are their vessels big where they have pain, or is it explained? And also, are those vessels functioning? So they get them to basically bear down in the ultrasound and see if they get backflow when they bear down and if that reproduces their pain. And from there, we kind of work forwards from there. So I then obviously do refer them to James, and we do some further imaging workup, which I can let James speak to. But we just want to go looking for varices where there's pain if we suspect that there's a venous component.
Right, James, so what's happening at your end when you see these ladies that have been sent across by Sarah?
So when they're sent across by Sarah, they're worked up pretty well. So I'm breathe a big sigh of relief that what I'm seeing or what I might see will then be significant to that patient. And that's, I guess, something to note is that plenty of people have big veins and they might not necessarily be significant to that patient. And I think, again, that's probably where things have become confusing through the last decade or so, as far as whether this is a believed condition or not. So primarily the symptoms have to be there and they have to be described to me as far as location and lateralization. So when we get these images, the primary thing we're looking for is reflux. That's on the refluxing kind of pathophysiology of these pelvic venous disorders. The obstructive side of things would be, thrombotic or those anatomical pinch points and etc. But if we put that aside for a moment, we're talking about the refluxing side of pelvic venous disorder. That's what we're looking for. We're looking for flow reversal. Now, ultrasound is a good tool because we actually get to see the direction of blood flow in real time with various maneuvers, either Valsalva, bearing down. We can sometimes get into reverse Trendelenburg or even get patients to kind of sit up or stand up. But that's what we're looking for. I've been completely caught out on a CT with plumb, almost normal veins, and certainly well below, thresholds of 6 millimeter diameters and things that are reported in the literature. And I said to Sarah, I'm like, oh, sorry, you've got this one wrong. Go look for something else. And Sarah said, she is classic pain. And so we moved on to then the gold standard test, which is a catheter venogram, where we place catheters into the veins and can actually squirt some contrast dye and see it in real time. And this plumb normal vein on a CT when the patient is lying flat at rest in their absolute most comfortable position for these patients, at the start of the day when they get out of bed or lying flat in bed, they're most comfortable. You stick them on the CT and all of a sudden these plumb normal veins from my eyes were gigantic and completely refluxing. So I'm really, when we see it, when it's positive on imaging. When it's positive, but when it's negative, I listen to the symptoms and the patient, and that's what I am concerned about. First and foremost, I'm treating a patient and I'm not treating an image. And this is, I think, where people can kind of get unstuck.
as a GP, can I order a CT venogram of someone's pelvis? Or what sort of test? Or there's an MRV. There's other things. What sort of options do I have?
If I'm a GP in Adelaide or somewhere else across the country and I want to know how to get these people screened and how to get started, can I encourage you to send them first for an abdo and pelvic Doppler ultrasound and put as much clinical detail on that form as you can manage and put query, zone, whatever, 1, 2 or 3, and we'll go through where that is, pelvic venous disease or pelvic venous disorder, and that flags it to go to a radiologist who has the confidence to actually look at it, and that will give you a report that you can then go, right. And once you have that information in your hand, you then need either an interventional radiologist or a vascular surgeon. So start with Doppler, and then if you get that and you get that flow reversal on Valsalva, you need to go to CT, but you need an IR or a vascular person in your corner, and you need to refer it to the person who's going to be doing the intervention, so that, because it's their roadmap, they want to know where they're going. And so what you don't want to do is just go, rightio, that's happened and we think we've got that, and please don't send them for a CT pelvis, because you're telling the radiologist not much. Have they got a bowel obstruction? Have they got something else going on? And that doesn't give you the answer that you want. So you want, in a nutshell, you want a abdo-pelvic Doppler with as much detail as you can muster and query PVD on that scan. And then you want to refer to an IR or a vascular surgeon who treats this condition in your area.
So yeah, the options do kind of work their way up, and this applies to most any medical condition. There's always a quick and easy test and a cheap test, and it captures most people, and that's generally used as a screening test, and that's the ultrasound test, really. For me, I use CT abdomen to pelvis venograms or CT venograms on all my patients, and it's not necessarily used as a diagnostic tool, but for me it's a roadmap, because these patients are generally being worked up symptomatically well enough to know that we're going to likely do something, and they've had the ultrasound to say that there is flow reversal, but we're not sure, say, is there a mechanical pinch point that we have to work out? Is there a nutcracker or an anterior or posterior nutcracker, or is there a May-Thurner that we need to be aware of when we're going in? But also, where are these vessels and how many of them are there? We use contrast dye and we use radiation in the catheter venogram, and by far when we have a roadmap, being a CT, I use less contrast and less radiation in the venogram. So the CT happens next for me. And then on all of my patients, the treatment phase is a 2-stage. So first of all, the gold standard catheter venogram gets performed, and that is done as a planning study. So it is to exclude definitively obstructive causes such as nutcracker or May-Thurner, because they get treated.
Yeah.
Exactly. Look, if I could encourage any of your listeners, physicians, to read one article on this, at least to kick off the conversation and to help people understand the pathophysiology, but also to understand the process for patients, it's this article. This is a classification system of how to approach people with pelvic venous disorder. It is a symptoms first, and then a varices second, and then a thinking of the physiology third, a way of classifying pelvic venous disorder. In the body, and just thinking about the pelvis for a minute, there are certain zones of venous reservoir. So zone 1 is your left kidney vein. Now, the IVC sits, so the inferior vena cava, which takes all the blood back to the right heart, sits on the right side of our body, and the aorta, which is not shown in this picture, sits on the left side of the body, and it'll run down beside the IVC, and the big, fat, high-pressure aorta will run behind the left renal vein. And in most people, then the superior mesenteric artery, which is a high pressure hose that feeds the gut, will run out of the aorta above the renal vein and will run over the top of the renal vein. And depending on how closely opposed they are, it can pinch that renal vein. If you look side on, it looks like a nutcracker, where the renal vein is the nut, and the aorta behind the renal vein, the SMA in front of the renal vein, is the nutcracker. And that will pinch that renal vein.
So it just gets
Now,
squished. So
it just gets squished,
it's a blockage on the highway.
Yep, that's right. This is the blockage, the obstructive cause we're talking about, rather than, say, the refluxing cause, primarily as the primary pathophysiology. Now, again, there are various criteria to work out whether this is a problem for the patient. Symptoms are by far the most important, and flow in the catheter venogram. So what symptoms can occur in zone 1? The classic nutcracker symptoms of left-sided flank pain, hematuria. But that reservoir eventually has to spill somewhere if there's an obstructive cause, and that left kidney will spill into the left ovarian vein. It's like the stack of champagne glasses, and you're pouring the champagne in at the top. It'll eventually fill and then spill into the next one. So that's an obstructive cause in zone 1. The wrong way to approach it really is the quick and easy way is to say, let's just go see if you've got varices anywhere, disregarding your symptoms at all. And that's where we come into a situation where, some people might have some veins here or there, but if they're not symptomatic, they don't bother the patient. Male equivalent in this, and this is probably the example which will sit most with primary care physicians or physicians seeing patients all the time. The male equivalent is the varicocele. And you would agree, anyone would agree with me that there are men who come in who examine with a varicocele and have absolutely no symptoms at all. Varicoceles are incredibly common. And then there are other men who have classic symptoms of, say, a left-sided varicocele and examine as a left-sided varicocele. Now, in that patient, that male patient who comes in with left testicular pain and a palpable varicocele.
And that being the sort of classic bag of worms that we
bag of worms
medical school that you can see, those veins.
Exactly, and that you as the physician can see and you can palpate and you can feel. Now, if you've got that patient in front of you, there is no imaging test that's going to tell you that you're wrong, right? There's no imaging test. You're not going to order an ultrasound, for instance, and have someone trace the gonadal vein and say, do you know what, it was 5 millimeters, it's not 6, so I'm sorry, you're wrong. Yeah? So
and it's just another example of women getting screwed over because you can't see these on the outside.
Absolutely. So this is, again, a situation where there's obviously gender bias. So there's gender bias for the patient, but we have to be really wary of a physician bias as well, because we can't, in the male, we can see it and we can touch it. And so all of a sudden we're right because we've done the test ourselves and we can physically see them and palpate them. And in the female, that just isn't necessarily possible all the time. And so we have to actually address our own kind of confirmation bias or physical exam bias as physicians ourselves. Just because I can't see it externally or palpate it externally does not mean it's not there. No one's going to deny someone with achy, itchy legs and great ropey veins that they have a venous disorder of their legs, nor are they going to deny the 23-year-old male with a bag of worms in his left scrotum and a really sore testicle. They're not going to deny that person that diagnosis. So we have to understand that even as physicians, we have a bias to what we can see and what we can feel.
James, you're an interventional radiologist, so you're not just looking at the pictures and telling us what's on them. You're getting in there and doing some interventions as well. What are some of the common interventions that you do in this area? Obviously, if the decision's been made that we think that the pictures are lining up with the symptoms and we think this is a contributor to someone's symptoms.
we first have to decide whether it's a primary reflux disorder or obstructive disorder of these veins. Now, by far, it's reflux. The obstructive causes are just rarer. Not that they don't exist or even coexist, they're just rarer. The classic patient who will present will be in their mid-30s with 2 or 3 kids, and she says, the first kid was fine, the second kid was pretty bad, and the third kid was an absolute bugger, and now I've got all this pain. And so they'll be in their mid-30s, having huge doses of estrogen during pregnancy, and they'll be refluxing. And so it's time to take out that bad highway, to take out that disordered and dysfunctional vein, to recognise that the vein is just not working for them anymore, removing it from the system and allowing their pelvic organs to find other veins, smaller, with intact valves, to push the blood out so that when they stand up or bear down, it doesn't fall back into the pelvis again. This can be done through various techniques, but the way I typically do it is through both a coil and a liquid embolic closure of those veins. Some people use multiple coils and sclerosant. I typically use only 1 to 2 coils at the top of the vein to basically close the door on the point of reflux, but then fill up those veins with medical glue so that that big diseased vein is completely taken out. There can be no little collaterals finding their way back to that main highway so that the traffic can recycle into that. The patients will firstly, for me at least, come in for a diagnostic catheter venogram, as I said, so no treatment. And it's where I put a little catheter into the vein of the neck on the right side, and I can point my catheter down to test each of those 4 escape points. So we test each of those veins. The veins that we want to treat, we'll name, obviously, and measure their diameter. Then I'll bring them back after the discussion with the patient to say, it's both your left and your right ovarian vein, which is dysfunctional. Whatever we find that has refluxing blood, we treat. So the treatment involves then coming back, blocking off the top of the vein with a coil, and then filling up that vein, in my practice, with medical glue. Other people fill it up with multiple coils or sclerosant. And then from beyond that, what people experience afterwards, they generally have an exacerbation of their pain, and that's pretty typical. The glue and the sclerosant, and really we're thrombosing those veins as well. It will exacerbate their pain for anywhere from a few days to a couple of weeks. What I say to my patients is we're basically causing a bruise in there, and you know exactly what it's like. If you get whacked on the leg, you'll often hurt at the time you get whacked on the leg, but when you really hurt is when it goes all purple and you touch it a bit 2 or 3 days later. So often patients will come out of the procedure and they ache and they say, oh, geez, it hurts here. And I say, is that where you usually get your pain? And they say, yes. And I say, that's good. That's what we want.
So it's going to get worse before it gets better.
Yeah. It's really just an exacerbation of their typical pain and right in the location of their pain. They will go home. I do it as a day procedure. They're not admitted overnight, so they just come in, I have it done. It takes me an hour or so. They go home the same day with some pain scripts, and usually they'll be entirely functional by day 1 or 2, and some niggling pain maybe up to a week or 2. And typically, the bigger the veins, the longer the duration of those exacerbation of symptoms, and it really is just we're forming, clotting off all these veins, and it just takes longer for that inflammatory response to resolve. It's exactly like thrombophlebitis in the arm. A big area of thrombophlebitis, it's going to be, painful and irritated for a lot longer than just a little small section.
So that is where you're fixing the reflux.
So from an obstructive cause, there's 2 points of obstruction from an anatomical cause we've already talked about. There's the nutcracker up at the renal vein, and there's the May-Thurner point down at the left common iliac vein. The data is pretty clear on this, is that a stent, which is essentially a wire cage to put in the vein to brace it open, it looks like a roll of chicken wire kind of thing, they do well in the left common iliac vein. On the other side, on the upside, on the renal vein side of things, A stent can be placed, but the literature and the data is pretty clear that they don't do well in the left renal vein, and so I don't stent them, and I have a vascular surgeon that I will send those patients to for discussion around operative management.
Sarah, I think you might be our one to wrap up today, because it's always great to take it back to the patient, and you know some of the women that you're working with who are dealing with some of these things. Any last thoughts on what this journey's been for you and your patients?
I think if I can impress anything to wrap up this session, it's that the pain is what the patient says it is, where the patient says that it is. And that when we are looking at even patients with endometriosis or adenomyosis or some other form of pelvic pain, they may have myofascial pain, they may have nerve pain, they may have nociplastic pain. What we need to remember is that pain with endometriosis doesn't necessarily mean pain from endometriosis. And that doesn't mean that every person is going, and every person with a venous problem doesn't necessarily have venous origin pain. When we truly listen to what the patient is telling us, they will give us the answer that we need to help them to get better. That's just what I would like to leave people with.
Sarah Thorncraft, James Hillhouse, what an absolute cracker of a conversation. Such an important topic that is just not being discussed enough. Can't wait to find an opportunity to catch up with you both and discuss further. Let's keep talking about veins.
Let's.
Absolutely.
See ya.
Thanks for having us on.
Okay.
Thanks so much, Alecia.